The radical. Fundamental principles of freedom, rational self-interest, and individual rights. This is the Yaron Brook Show.
All right, something weird is going on there. There seems to be a nice echo to music. Anyway, welcome to the Yaron Brook Show. I should put on the video, shouldn't I? Yeah, here we go. That's better. Echo, echo, echo. It's only there. I don't think, you're not hearing an echo from me, right? I think it's just, anyway, the music. The music. All right, thanks for joining me, everybody. Really appreciate it. We are going to talk about healthcare today. We're going to do to healthcare what we try to do to financial regulation, to China policy, to, what was it, immigration, and now healthcare. I mean, at the end of the day, what we will have here, I think, by the time we finish the series, is a blueprint for how to move the U.S. economy, how to move U.S. politics, how do you move the U.S. government towards having a rational policy overall. So this is a roadmap for all of that. Maybe we can get transcripts of this and get it all in writing and put it on a book called, Rational Policy for Irrational World. Rational Policy for the world in which we live. So it's going to be a plan. So I will be kind of using the same template I use with immigration and with China policy. I think to some extent I keep making slight changes to it, but generally, this is the template. This one is sponsored by a few of you. So a few of you sent money in. Let me also say this. This is a big one. Healthcare in particular. It's like finance. As I said, in finance, it can't be done in one show. And I didn't try to do every aspect of finance and everything in finance. You can't do healthcare in one show. There's so many dimensions to this. We'll cover a lot, but we could go in depth into any one of these. And I am not familiar with all the laws and all the regulations and all the complexities associated here. So we're going to take a kind of big picture. We're going to go into more detail on things that I know and understand and think are important. But we need a few shows to do this, and we will be doing more shows on this. So stay tuned. There will be more healthcare shows. This is show number 1. Thank you for those of you who have sponsored this show. Let me just put it out there that if anybody out there wants to sponsor a show on, I can think of education would be really, really good. Somebody suggested labor laws. Labor laws would be good, although I probably have to bring in somebody. No, I mean labor laws. I could do labor laws. And think about anything else, any other realms that you might want me to cover in this way on the show. I mean, we've done one aspect of foreign policy, China. We could do other aspects of foreign policy. We could do the Defense Department. We could just do a show on the Defense Department and what that would look like. But so basically it's $1,000 a show, but we can aggregate. I think this healthcare show, we had a couple of people do $500 each, and hopefully, if you guys want to do education or one of these others, we can put together. Whether it's 250 each or 500 each, or we can put something together to make that happen. So just let me know if there is interest, and we'll organize it. And of course, if you have ideas for other topics, let me know. Environmental regulation would be a pretty good one. I don't think I have anything to add to what Alex publicizes on a regular basis on energy policy. Environmental law would be really good. What would be the government's perspective on environment? And then we could do more on finance, and we will do more in healthcare. So what to do with federal lands? That's easy. That will take 10 minutes. 5? 3 sentences, 2 words, 2 words. Here you go. Here's what to do with federal lands. Sell them. Sell them. Auction them off to the highest bidder. That's it. That's what I have to say about federal lands. We can talk more about it. We can do a show about that. Anyway, please let me know what you want. Now, in terms of today's show, you can ask questions. Again, you can ask questions about anything. I will give priority in terms of time to the questions about healthcare. So any questions you have about healthcare policy, comparison to other countries, NHS, I don't know that much about, Switzerland or some of these other countries that have hybrid systems, but I know something about the NHS, a little bit about the Canadian system, a little bit about the Israeli system. Those are the international systems I know of. I know about. I don't know that much about the other systems, other than a few things that I'll say at the beginning of the show here. All right, I think we've kind of summarized it. Yeah, we can do one on gun laws. Whoever puts the money up, that's what we'll do. This is market-driven. The Yaron Brook Show is very market-driven. Whoever puts up the money, you don't get a say in what positions I will take, on what opinions I hold, on what recommendations I make, but in terms of the broad topics, we can do that. We can do that. All right. So let us start with healthcare. Again, Super Chat is open. We have a regular goal, and this will probably go long just because I have a lot to say. Of course, there might not be any questions, so it might be short. And what else did I want to say? Yeah, you get to ask the questions and feel free to ask about anything, but priority will be given to healthcare. All right, so one thing I think everybody can agree about when it comes to healthcare is that it seems that pretty much nobody is happy. Nobody is happy with the system. Now, it might be true that healthcare right now is not a big issue politically. It's not top priority for Trump. It's not top priority. Wasn't top priority for Biden. Since Obamacare, there was some movement to abolish Obamacare, but other than that, there's been very little really excitement and very little emphasis, very little focus on healthcare over the last few administrations. And the system just keeps chugging along. We'll talk about what that means, but it just keeps going. And nobody wants to touch it. And a big part of nobody wants to touch it is everybody knows the complexity of doing anything with healthcare. And more importantly than the complexity for this purpose is the number of pressure groups, the number of people who have an opinion, who have a view, who are going to fight tooth and nail for whatever it is, for their piece of the healthcare pie, if you will. So the amount of pressure group politics here is as bad as probably in finance, and really, really, really horrific, much worse than immigration or almost every other topic because of the complexity and the scale of this issue, right? The scale. While nobody's unhappy with the system, healthcare in the United States is massive, right? It is a $4 trillion expenditure a year. It constitutes, last constituted, I think in 2023, 17.6% of GDP. A massive portion of government spending goes to healthcare. Medicare and Medicaid are a huge chunk, about $2 trillion of government expenditures. So in a $28 trillion economy, we spend about $4 trillion, $27 trillion economy, $28 trillion economy, we spend about $4 trillion on healthcare. Think about $4 trillion in healthcare as $90,000 per person. I mean, it's huge. It employs millions of people. It is a massive industry, which nobody's excited about. Nobody is particularly happy with. I mean, you hear lots of complaints. It's super expensive. And as a percent of GDP, 17.6 is the highest, I think, in the developed world. I don't know in the world, probably in the world, as a percent of GDP spending on healthcare. And, you know, other countries are closer to 12, 13, 14. Nobody even comes close to the 17.6. And yet, the argument is, I'm not saying this is true, but the argument is that outcomes are not that much better. That is, life expectancy, the broadest outcome that people measure, is lower in the United States than most of the developed world. Now, that number's cheating. There's a lot of cheating going on with numbers generally to make different points. Life expectancy in the United States is lower than the rest of the world at birth. And that's because of two things, basically. One is, it is the case that infant mortality at childbirth is higher in the United States than the rest of the developing world. But the big difference in life expectancy at birth is unrelated to healthcare. It's related to drugs, suicide, crime, traffic accidents, which all, as a percent of the population, are very high in the United States compared to the rest of the world, and are actually the things that cause, did I say drug overdoses? If not, I should have, drug overdoses, have led to a decline in life expectancy. You should also say that a big issue here is obesity, which the United States, I mean, the UK is pretty bad, but I think the United States is still the most obese country in the world. Maybe the UK is worse. Maybe there are a few other places, but generally it's really, really bad here. So if you take into account all those things that have nothing to do with the delivery of healthcare, they're the ones that have an impact on life expectancy. Interesting fact. Life expectancy of Americans who reach 70 years old. So life expectancy of people who reach 70 years old, higher in the United States than anywhere else in the developed world. So once you can take out all the other factors and just focus on, in a sense, healthcare delivery, we keep people alive really, really well. People always complain that healthcare in the United States is not universal. Not everybody has access to it. Not everybody can afford it. It's because it's so expensive. It's not just expensive at kind of a national account. It's expensive for individuals. And therefore, there are people who supposedly can't afford it. And as a consequence, you know, it is not universal. And there are horror stories of people who don't get healthcare in the United States dying. And if you go outside the United States, in the UK and in Europe, everybody believes that basically people are dying in the streets on a regular basis for lack of healthcare in the United States. It's really the amount of mythology that exists in the UK and in Europe about the healthcare system in the US is astounding. Add to that the fact that people get denied health insurance and people are upset about that. And that, again, there's a huge mythology out there that many people in the US die or do not get treated because they're denied coverage. You know, I got so many stories from my debate in Cambridge where the audience was like, you know, I would have never got treated for this and this in the United States. I was born with this disease, and I would have never got treated. I was born with this, you know, handicap, and I would have never got treated because I couldn't afford it, you know, in the United States, which is mostly 99% of it is 99.9% just not true. And then finally, the one big problem that exists with regard to costs, which is real. I mean, the U.S. in many respects is expensive, but we'll get to whether that's real or not. But the one way in which it's really expensive and is that basically healthcare costs are bankrupting the federal budget. In other words, Medicare and Medicaid are unsustainable. Spending on Medicare and Medicaid is just unbelievably expensive, and not sustainable if you look into the future. Something has to give. Given the amount of revenue the United States brings in, it cannot sustain Medicare and Medicaid spending at the rates that they are. So we do have an obesity problem, which is blamed on the healthcare system. We have a service denial problem, which is blamed on what we call health insurance. There is a quality of service, primarily. People complain about the very little time they get to spend with doctors. Doctors complain about the very little time they have to spend with patients. There's very little, if any, preventive care, or very little of it, and there's very little emphasis on it. Physician compensation has declined in real terms or been stagnant, and the quality of life in terms of the quality of the enjoyment of the profession in terms of time with patient, time solving problems of physicians and healthcare people in the healthcare system is down. The system has no real transparency. We don't know how things are going to cost. We don't know exactly what we're consuming, how much we're consuming. There is complete mystery about healthcare costs from the consumer's perspective. So all of these and many, many other things are real costs, are real problems in the United States, and people are frustrated and people are upset. Their insurance premiums, they are paid by primarily the employers. We'll get to that. But, they pay an ever-growing portion of it, and it's expensive. And, as we'll see, there are all kinds of distortions and perversions that are caused because of the system, the way it's comprised, that just creates uncertainty, angst, and frustration. So what is it about the system as it exists today? What is it about the policy, the healthcare policy in the United States as it is today, that has caused the system to be as frustrating and as upsetting to people as it is? So let's go over kind of the way the healthcare system is structured today, and the way this leads to these frustrations. So I think that we should start with kind of the way most of us experience the healthcare system. And the way most of us experience the healthcare system is through the purchase of insurance. And while insurance is not the delivery of healthcare, insurance is the way we fund healthcare, and the insurance dictates to a large extent what kind of healthcare we actually get. So we need to step back here and talk about what insurance is. Real insurance is something that covers you for rare, unexpected, and significantly costly events. So insurance is a mechanism to protect you from things that are unexpected, unknown. That is, there's a huge amount of uncertainty around when they will happen, if they will happen, and where the cost could be very high. So think about it. What's the probability your house will burn down? It's very low. Do you know when it will happen? No. You can't predict when it will happen. What are the financial consequences of your house burning down? Pretty catastrophic. It's really bad. It's a lot of money. Think about auto insurance. We buy auto insurance not for our regular service. It doesn't cover kind of the 3,000 mile or whatever service. It doesn't cover oil changes. For the most part, it doesn't even cover like little dents and bumps and stuff like that. It covers you really for when you have a significant accident, and the cost can be thousands of dollars. Now, it's not as expensive as a fire burning down your home. The probability is higher that you get into a car accident and your home burns down. And it's less expensive, but it's still, relative to the cost of the car, a lot of money. So you buy insurance to cover that. You don't cover the little bumps and the little things, and you don't cover maintenance. Life insurance. You don't know when you're going to die. Dying, let's say, when you buy life insurance, typically a good age to buy life insurance is when you start a family and you've got dependents, and you want to make sure that if you drop dead, they have some money. And so you want to buy life insurance to cover you from age, 30 to 60, something like that. Those 30 years is while you've got a family and they're dependent on you, and you want to be able to, if you die, they get $1 million or whatever, you want to be able to cover it. You don't know when it's going to happen. What's the probability you die between 30 and 60? Pretty low. And it's catastrophic. It's catastrophic. And think about business interruption insurance. Think about all the kinds of business insurance. Think about maritime insurance. The ship, sinks. Pretty low probability. Uncertainty about it. Catastrophic. And yet, health insurance doesn't work that way. And it doesn't work that way because it's really not insurance. It's really not insurance. It's a form of risk pooling. It's a form of redistribution of wealth. But we really should not call it insurance. It doesn't have the characteristics of insurance. If I have a cold and I go to the doctor, that's going to cost me $50, maybe $100, maybe $150 if you have a relatively expensive doctor. It's not catastrophic. It's pretty common to get a cold. I get one once a year. Pretty common to get a cold or to get the flu. And yet, we cover it. If you have, diabetes, and you have to get, insulin, or you have to get diabetes drugs or whatever, and now it's a constant cost forever. Insurance covers it. We cover things. We cover relatively minor, relatively low cost, recurring, expected events with this insurance. So it's not. And of course, we don't even buy the insurance. We might choose, if our employer has options, we might choose between different health insurance plans. But we're not really buying them. Our employer is buying them. And our employer is buying them, they're the ones who have a contract with the health insurance. And one of the issues with these insurance policies is they're not ours. So, for example, if you leave a job, you don't have insurance anymore. You're not covered. I mean, there are laws in place that allow you to continue to get COBRA, and the employer, by law, has to contribute towards that COBRA. And COBRA is a continuation of your existing insurance policy for a certain amount of time. But it's not really your insurance policy. The employer has bought it. It covers you, but it's their policy. They pay. So one of the problems we have is that we don't really have insurance. We call it insurance, but it really isn't insurance. We have a third-party system where our employers get us insurance, and then we get to consume healthcare and basically bill it to the insurance company. I mean, this creates all kinds of moral hazards. It creates overconsumption. It creates a system by which we don't care about the cost of insurance. By the way, the cost of insurance has nothing to do with your health. The other thing about insurance is, we've talked about this in the past. In fire insurance, the insurance company determines the premium based on, for example, how likely it is that there'll be a fire in your area that your house will be caught up into. So some areas in California that have very, very, very high fire insurance because the likelihood of a fire is relatively high. Other places, really cheap because the likelihood of a fire reaching you is very low. Same with flood insurance, although flood insurance and earthquake insurance, very distorted markets, but when they functioned, where you were, the risk that you would, the risk that you are susceptible to this catastrophe is taken into account in your premium. Health insurance companies don't assess the risk of you receiving a disease. For example, you and your coworker, you might be the same age, but he might be, I don't know, 100 pounds heavier than you. Now, the fact that he's 100 pounds heavier than you makes him susceptible to diabetes. Diabetes makes him susceptible to heart disease, which, and even cancer. It makes him susceptible to potentially to Alzheimer's at a young age. Insurance company, they don't care. I mean, maybe they care, but the system is not structured to take that into account. None of that is relevant. Indeed, it's illegal for them to take any of that into account. You might have a gene that makes you more susceptible to certain cancers. They can't take that into account. So they're pricing off of a pool where they're basically estimating the relatively ages of the people in that pool. But that's really the only, and sex, age and sex are the only parameters they can play with. And they figure some are obese, some are not, and they come up with an average price, and then everybody pays basically, I think there's an age adjustment, but everybody pays a price based on your age, and that's it. So again, not insurance. What we have today in the United States is a mechanism by which we redistribute wealth, we distribute health expenditures from healthy to sick, from young to old, but don't call it insurance. I mean, we call it insurance because that's what everybody calls it, and it's the way it's called. But it is not insurance, not by any financial measure of it. It's pooling of risk. It's a pooling of risk without, to some extent, a blind pool of risk. And by the way, so now why do we do that? Well, I don't want to get into the entire history of it, but the basic idea is that employers versus employees have an advantage in buying health insurance. If an employer buys health insurance, the health insurance premiums are tax deductible. If you as an individual buy health insurance, your health insurance premiums are not tax deductible. So you have a huge advantage in letting the employer buy the health insurance for you because they do it with pre-tax dollars. And if you did it, you would be doing it with after-tax dollars. So again, that provides a massive incentive for employers to buy the health insurance. And a lot of employers don't even buy insurance. They have insurance companies administer what they call insurance, and they're really, in a sense, self-insuring. They're creating reserves, financial reserves, and it's their money that is paying out. It's not the insurance company that pays the money out for your health care, but the company does. So the fact that we have an employer-based system, the fact that our system, by regulation, is not an insurance system, but a pooling of risk, a redistributive system, is at the core, I'd say one of the two cores of really all the problems that we have today in healthcare. The other is that about 50%, actually it's over 50% of all healthcare expenditures are spent by the government. Basically, the government covers through its so-called insurance policies, right, Medicare and Medicaid. The government covers 150 million Americans. I mean, people say you don't have a single-payer healthcare system. Well, 150 million Americans have a government healthcare system. That's about 90 million people. 90. I didn't realize the number was this big. 90 million people on Medicaid. Sorry, yes, Medicaid. That is healthcare for people who cannot afford insurance. This is supposedly healthcare for the poor. That includes CHIP, which is the healthcare for children whose parents cannot afford to buy insurance. And so that's 90 million and 60-something million, so it's over 150 million. 60-something million people on Medicare, which is basically everybody over the age of 65. No matter whether you can afford it or not, everybody over 65 gets Medicare. And that number will grow to over 70 million by 2032. So we have a government-run healthcare system that basically provides healthcare funding for 150 million Americans out of 350 million. So it's a big chunk. It's not quite half, but it's 40%, 35, 40% is all government and 50% of the expenditures. Because when do you spend the most on healthcare? When you're old. That's all covered by government. All covered by government. All covered by government. Right? Because Medicare pays for 65 and over. So you have a situation where 50 cents of every dollar spent on healthcare, actually more than 50 cents, is government expenditure. So we don't have a private system. We have a pseudo insurance that's not an insurance system. And we have a government system. Those are the two alternatives. And the government system dictates a lot because it's massive. So let's take Medicare. Medicare represents let's say 62 million people. All age 65, huge consumers of healthcare. And they're all getting hip replacements and bypass surgeries and cancer treatment, right? And so when doctors and hospitals are billing for all those treatments, they are facing this kind of monopoly. There's only one entity representing people over 65. And so who has the pricing power in that relationship? Well, clearly the government does. So the government can dictate prices. The government can drive prices down on some things. And by driving prices down, for example, doctors get very little money from Medicare for really complicated procedures. It's sometimes hard to believe how little money they get per procedure from Medicare. And hospitals have to negotiate with Medicare, and Medicare drives prices down. And now, hospitals and doctors and everybody else still have to make a living. They still have to make a profit. And there's a sense in which they make the profit off of driving up the price for private insurance, for the insurance that's outside the Medicare system. So you get a system in which the private so-called insurance is subsidizing Medicare and Medicaid. And of course, one of the big controversies right now is, should Medicare and Medicaid be able to negotiate drug prices? Because if they can negotiate drug prices, they can lower drug prices dramatically, like European countries have and like Canadian system has, by basically, being the dominant buyer of a drug in the economy. And if they can drive down prices dramatically, either drug companies now, their profitability plummets, which reduces the availability of capital for them, which reduces R&D and all the other consequences, or drug sales to private individuals through their so-called insurance policies have to go up. Something has to give, right? The money has to come from somewhere. And if the government's going to squeeze drug companies, as so many people want it, the Biden administration has already started the process towards that, and Trump has indicated he would like to continue, then, drug companies are going to be, profitability is going to be squeezed completely. And given the cost of drugs and the length of development and the expense of developing them, what happens then? What happens then? So the fact that the government is such a big buyer of healthcare services is a major, major, major problem, which basically distorts the pricing of healthcare in the United States. As a consequence of that, what you see is massive cross-subsidization. Healthy subsidizing the sick, we talked about that. The young subsidizing the old, we've talked about that. Again, we're all subsidizing the Medicaid that the old get after 65. Those of us who are not yet 65, I'm not quite there. I'm almost there. And insurance companies, or the so-called insurance framework, it's not the companies, it's the people who pay the insurance, are subsidizing government programs. Huge amount of cross-subsidization. And it's really hard to keep track of it. I mean, I don't know that anybody has in terms of the actual numbers, but keeping track of it is almost impossible because it's going on all the time and it's super complex. Now, top all of that off with the fact that healthcare is heavily, heavily regulated. So these pseudo-insurance policies, what they offer, how they offer it, is unbelievably regulated. What you can and cannot offer, what kind of policies, the kind of deductibles, the kind of coverages. Now, most of that regulation, not all of it, but most of that regulation is done at the state level, but that means there are 50 different types of regulation. It also means that because of that, if I live in California, I cannot buy a health insurance policy from Nevada. I can only buy it in California because health insurance is regulated at the state level. And you cannot buy across state lines health insurance. So there's no real competition. So it's heavily regulated at the insurance level. I mean, every aspect of what you can buy. I mean, if you look at the Obamacare exchanges, the policies all look very similar. And they look very similar because there's only a range in which they can play around. They have to cover, I don't know, psychological care. They have to cover pregnancy. They have to cover all kinds of things. In California, alternative health care, like acupuncture has to be covered. All kinds of stuff like that. And then the deductibles cannot be too high. You cannot get catastrophic health insurance. It's very difficult to find a state where you can actually just buy catastrophic health insurance. We'll get to that. That's insurance. But then everything about the delivery of health care is regulated. Hospitals. Massive regulations on hospitals. We saw that during COVID. And isn't it interesting that given the failure during COVID, the lack of capacity, the lack of communication, the bad policies coming down from government, vis-a-vis COVID, that healthcare, there was really no reform. There's really no lessons learned, not just about how to deal with the pandemic, but maybe there's something in our healthcare system that is not working right. For example, you remember there were hospital bed shortages. Why is that? Well, it turns out the state governments regulate how many beds you can have in a hospital. And if you want to expand, you have to get permission because they're looking at something about competition within a particular band. In the 1950s, there was passed a law that said that within every certain radius, there has to be a hospital. So lots and lots of hospitals were built. Some of that has gone away. But again, where hospitals are, how many beds they have, what kind of services, for example, emergency services or not, they can provide, all regulated, all controlled by government. Heavily, heavily regulated. And of course, what a doctor can prescribe you, what kind of drugs are available, the whole issue of drugs, massively regulated, massively controlled by government, the FDA, and the whole process of getting drugs to you, the whole reason it's so expensive and it takes so long is because of the extent of regulations. And then finally, well, not finally, because I think there's a lot more that I'm not even getting to, but there's the supply of medical staff is regulated, is controlled. Doctors, nurses, people who work in hospitals, their licensing laws vary across states, but are pretty stringent. There are restrictions on funding for medical schools that can increase the number of doctors or decrease the number of doctors depending on decisions that are made in terms of funding medical schools. And then there's immigration, the fact that doctors who are highly qualified, who are being trained in the best universities in the world outside the United States and are licensed in those other countries are not allowed to work in the United States and cannot get immigration visas, or it's very difficult to get immigration visas to come to the U.S. to work here on a permanent basis. So we've got a financing system that is completely messed up because it's not real insurance. And it creates moral hazard, which means overconsumption. It creates distortions of pricing where we as consumers don't know and don't care how much any procedure costs. We just don't care. As compared, for example, to LASIK, which is not covered by insurance, where we do care how much it costs, what is the other one? And prices have come down, by the way. And plastic surgery, which is not typically covered by insurance, and where prices of us come down, and there's massive innovation in both LASIK or health, eye health, different aspects of improving your eyesight, massive improvements, dropping costs, and certainly that's true of plastic surgery, lots of options, real competition, and we as consumers get to decide what to do, who to do it with, and so on. All right, so I've laid out kind of the system the way it is. Now, this is just a fraction of it, right? We haven't got into, how drugs are delivered through these, entities that sit between pharma and your pharmaceutical and your pharmacy. I just forgot the acronym just slipped out of my mind, right? PBSs maybe. Anyway, and they sit in between. I think most of them are owned now by insurance companies. I think one may be owned by one of the pharmacies. But these are entities that are supposed to make things more efficient, but have created massive complexity within the drug delivery and drug pricing. We haven't talked about all the other ways in which regulations drive and drive all kinds of distortions and perversions within the healthcare system. Pharmacy benefits managers, PBMs, not PBSs, PBMs. Thank you. The complexity is massive. Now, a free market would be pretty complex. We'd have actually more options. but it would be simpler for you as a consumer. All right, what should be our goal in reforming a healthcare system? We want a system that provides consumers with choices regarding treatment and cost, that maximizes individual health outcomes and avoids both personal and government bankruptcy, right? So a healthcare system that provides consumers of healthcare, with choices regarding treatment and cost, maximizes individual health outcome, and avoids both personal and government bankruptcy, and add to this, maximizes the freedom of doctors to exercise their profession based on their judgment. And that's something we also haven't talked that much about, the fact that so much of the system, so much of what doctors are left doing and what is covered and what is not covered and what is permitted and what is not permitted and so on is dictated by Medicare and Medicaid and big insurance companies. And so much of that is just, it's much easier just to regiment in certain conventional medical treatments and be conservative about, not trying new stuff, not being radical in how one delivers services, because we've got a particular way in which this is financed. So, for example, the Peter model, where you're not really paying him like you do a power, you pay him a retainer, if you will, or the concierge doctor model, is not covered by these insurance policies. Most of us pay insurance, and then we have these concierge doctors that we have to pay out of pocket. It's double the money. It's just overly cumbersome, overly complex, and way overly expensive. I have so many redundancies in the healthcare coverage that I have. It is ridiculous because I have concierge doctors. I have a very expensive health insurance policy because anyway, I have a very expensive health insurance policy, and I pay out of pocket for a lot of things, and yet I have this expensive insurance policy that just doesn't cover all the things that I value and that I pay out of pocket. So, this is the healthcare system we have. Why do we have it? Why is the healthcare system the way it is? Why is government so immersed in healthcare? And why have we taken decisions away from individuals? Now, you can take an historical perspective on this and see all the different points in which this was created. Remember, Medicare Medicaid are relatively new. In the 1960s, somehow old people and poor people survived in the healthcare system up until the 1960s. Yet Medicare and Medicaid were instituted. The whole idea of employer-based healthcare was introduced during the World War II as a way for companies who faced price controls over wages to increase benefits to their employees as a way of giving them a raise. They weren't allowed to give them an actual raise, so they gave them an added benefit. And then that was institutionalized in the 1950s, early 50s, by giving them a tax deduction on that benefit. But just imagine if during World War II, we didn't have a cap on wages, we didn't have price control on wages, then we wouldn't have maybe the employer-based so-called insurance system that we have today. So a lot of this happens incrementally, slowly. It builds, and then, as we know, every government intervention creates problems that then lead to more government intervention, that creates problems that leads to more government intervention, and we get this stacking on top, one on top of the other. You see this with Medicare and then Medicare Part D. You see this with healthcare, and all the regulations are like this. I have great examples on this from finance, but the same is true in healthcare. But what is the excuse given for why the government plays such a big role in healthcare? Why it basically covers the expenses of 150 million Americans? Why it's very difficult if you want to buy individual healthcare, why the government makes it so difficult for you, and why the choices are so constrained particularly at the insurance level, right? Insurance level, we have very, very limited options. I will say this, Americans want choices. And one way you can tell that we want choices is the failure of the kind of the PPO model versus the PPP model. The PPO model was a model in which you paid less for the so-called insurance, but you got fewer choices in terms of doctors and hospitals and facilities to treat you. Sorry, that's the HMO model. And then that's the HMO model. You get fewer choices in doctors, fewer choices in hospitals, fewer choices in places to treat you. The PPO model is wide choices. And while the HMO model was popular, 20-something years ago, maybe 30 years ago, it pretty much shrunk dramatically because people didn't choose it. People didn't like it. They didn't like restricted choices. People want choices. So the government keeps finding ways to reduce the choices while giving us the pretense that we still have them. Giving us the pretense we still have them. And why? Well, I hear these arguments all the time, why we can't have more free markets in healthcare. There's asymmetrical information. You don't know what's good for you. You can't judge a good doctor and a bad doctor. You can't judge what procedure you should take. There's too much, the difference in knowledge between you and the doctor or you and the providers of healthcare is too large. It's just too large. Healthcare is too expensive. And if we don't provide it as a government, you'll all go bankrupt. Healthcare will just collapse if the government doesn't provide it for you. There's no mechanism. The market does not have a mechanism by which to allow you. So people will just die, right? Poor people won't get any healthcare. They'll just die. Old people will just not be able to afford. Who can afford a cancer treatment? It costs millions of dollars. Some cancer treatments. So it's too expensive. And it's way too complicated. So, which goes through with the asymmetric information. In other words, you're not smart enough, most of you, and you're not responsible enough. A lot of you won't buy insurance, or you'll buy the wrong insurance, or you'll buy too little insurance, or whatever. And then finally, the profit motive. The profit motive is a really bad incentive in healthcare. It's going to lead people to try to, like everywhere. How can you trust the profit motive? The profit motive is about greed. And greed would lead people to undertreat you, as if that happens anywhere else in markets. Like in food. Do you get rotten food because of the farmer's greed? Food is privatized. It's not provided by the government. Do we get a lack of variety in food because of the farmer's greed? It's completely nuts. Completely nuts. So profit is an incentivizer to increase quality, actually reduce costs. It's to innovate. Profit is to provide great service. That's what the profit motive actually does. But people don't believe that. And then finally, and I think this is important, healthcare now is perceived as a right. I must have it because I need it. Because we all need it. We all need it. We all require healthcare at some point in our lives. Therefore, we must have it. There's a moral responsibility for it. There's a moral responsibility to take care of anybody, everybody. And therefore, the government must step in because we wouldn't fulfill our moral responsibility otherwise. Altruism demands it. And ultimately, it boils down to a really emotional argument. And the consequence of this, of course, costs are indeed high. Some people get service denial, but generally, we're not exposed to the best alternatives necessarily. You need to invest a lot in figuring out what's going on. If you are sick and you need treatment, complete separation of customer from prices. There's massive moral hazard. There's just a lot of unnecessary complexity and opaqueness and confusion, not just among customers, patients, but among doctors as well. I mean, think about how much time and effort doctors today put into the paperwork. How many people they have to hire to fill out paperwork? Paperwork. Everything's paperwork for to get reimbursed. And the time wasted waiting for reimbursements. And the effort exerted. So many doctors get MBAs, not so much because they want to grow their business, but because they just need to survive. They need to know some accounting. They need to know some stuff because it's become so complicated. So the real destructive consequences, and a lot of this has to do with destructive consequences to doctors, and I think doctors feel like they become bureaucrats. The producers of healthcare feel like they become bureaucrats. The producers of healthcare feel like, they're not being compensated appropriately to what they're doing. And a lot of people leave healthcare. The people entering healthcare of a lower quality generally. Healthcare is less rewarding. It's as it becomes more bureaucratized. And again, the talent pool is smaller. Fewer people go in for the right reasons, and all kinds of distortions in medical schools and so on. But just from a purely economic perspective, fewer people are going to go in because more bureaucratic, less opportunity to innovate, and expensive. Medical school is expensive, and salaries, income stagnant. And then think about drug companies and think about medical device companies and think about all of that and the degree to which we regulate and control all of that. To that degree, we don't get massive innovations, new products. I mean, it's stunning and amazing and heartwarming and, just amazing that we get as much innovation as we do. I mean, we get huge amounts of innovation. And yet imagine what we could get if we didn't control and regulate and mandate and so on. And I'm not even getting, one of the issues with healthcare that we should discuss, but we won't discuss today, is medical research, which is government dominated and is far from optimal. And it's a whole other topic. Think about the NHS and NIH, National Institute for Health, and all the money that the government gives out in grants and so on. Not an efficient, productive, method or outcome. All right. So we've described the system as it is, at least parts of it. Again, I'm sure there are big holes here. Let's talk about what we can do to fix it. And I think that there are two things that have to happen in order to fix the system. And the main thing one has to do is to reduce the involvement of government in healthcare. To reduce the involvement in government in healthcare in every dimension. So we need to reduce the amount of government regulation of healthcare. We need to reduce the amount of government regulation of insurance, health insurance. We need to reduce the involvement of government in actually funding healthcare, Medicare, Medicaid. Okay. Each one of those is huge. Each one of those, they're all to some extent interrelated. And of course, we need to change tax policy to change the kind of incentives in terms of who's buying insurance. So, and I'd say that's part of regulation of health insurance. So we need to reduce, eliminate regulation of healthcare providers. We need to reduce, eliminate regulation of health insurance. And we need to reduce and ultimately eliminate government as a provider of healthcare, direct healthcare financing. Now, all of that is a lot. We're talking about 17.6% of GDP. We're talking about the largest single industry out there. Again, employs millions and millions of people and spends $4 trillion. And we want to do it all in a way that does not bankrupt people, that does not have people who are sick dying in the streets, that does not disrupt medical innovation, that does not disrupt the ability of doctors to do their job. So we want to make the transition as smooth as possible, not that there are no costs. Whenever you have a system like this and you're trying to make it more free, there are costs of transitioning because so much infrastructure is built around this that disrupting it is going to, some hospitals might go out of business, some doctors might go, some insurance companies might go. There's going to be a repositioning of the whole system. All right, so let's think about how to do this. Let's take step by step. Step one is we want to phase out the employer-provided healthcare. We want to get employers out of the business of healthcare, of out of funding it, financing it, buying it, whatever, out of it. And we want to move to a system where individuals own their own health insurance policies. And we'll see that if we move towards individually owned insurance policies, that'll also be an opportunity to move towards real insurance. We want to, at the same time, completely deregulate the insurance marketplace. Now, I don't know how you do this because the insurance marketplace is governed state by state. Now, you could federalize it. You could say, states, you cannot regulate insurance anymore. It's going to happen at the state. It's going to happen. We're not going to regulate insurance. Here are a few standards by which you can regulate, but that means 90% of what you're regulating goes away. So you can't mandate what coverage, you can't mandate what deductibles, you can't mandate all these things. Or one alternative, if you don't want to completely trample on on the states, is to have a federal law that basically says you can buy insurance in any state and create competition among the states on who can deregulate the fastest. Who can deregulate the fastest? So you can have competition between states. So I'm open to either one of those. Ideally, I would love to see all state regulations go away. But the regulations about the kind of policies, the type of policies, what can be offered. And maybe a federal law could do that. And if it can, then it should. I'm not sure the Supreme Court would accept it, but it should try to get rid of state-level regulations. In that sense, it should federalize it. It was done in banking. There were state-level regulations that were basically nationalized and eliminated. So we need to do that. How do you move to individually owned healthcare policies? Well, you need to stop giving companies a tax deduction on healthcare expenditures. They cannot spend money. They cannot get a tax deduction. And then offer individuals a tax deduction, at least in the short run. Like could be a policy that is phased out over time, because I don't particularly like giving people deductions on taxes because I like really, really simple taxes with no deductions. But to solve the problem that we have, and maybe this would also be done in education, for a decade, let's say, you give people the ability to deduct their insurance premiums from their taxes at the individual level, not at the corporate level, not at the business level. Businesses have to pay taxes, cannot deduct insurance costs. Unless you shift the incentive to individuals. And for example, what about individuals who don't itemize, give them a deduction in spite of that? There are ways to do it, right? One way to do that is, to have a medical saving account. Medical saving accounts allow you to put money pre-tax into an account and use that money for healthcare, including insurance. And now you're not having to deduct anything from your taxes other than the money that you put into that account, which is not going to be taxed. That's a simple way to do this. So medical saving accounts should become universal. Everybody should have availability to them. They should be unlimited. Let individuals make decisions about how much money they want to put into a medical saving account. It doesn't make sense to put in, more than what you're going to use for healthcare. You should be able to roll them over from year to year, so this can become basically a way for you to save money for healthcare emergencies or for expected significant healthcare costs that come in the future. And you should be able to use that money to buy health insurance. Now, with a system like this, where I have a vehicle in which I can save money for healthcare expenditures, a system where I can do this in a pre-tax manner, a system where I own the insurance policy that I'm buying, and I own this account where I'm saving money to cover my expenses, in a sense, self-insuring. What it makes sense for individuals to do, and what I think individuals would do, is actually buy real insurance. Not a risk pool, but real insurance. And what that insurance would be insurance against catastrophic loss. This would be insurance that would cover you if you had to have surgery, or if you had a heart attack, or if you had cancer, or it would cover certain expenses if you developed diabetes. Maybe not all the expenses, maybe not the recurring expenses that you can expect, but some of the dramatic big ones. So, it would be a competitive market in which different companies would offer different coverages, and the market would figure out what made sense and what didn't make sense. You could imagine insurance policies that, and this is the way you could take care of, a pre-existing condition, insurance policies that covered you for life. Priced it today based on your health today, had a payment schedule into it for the rest of your life, and that covered just these catastrophic losses. You can imagine all kinds of things developing, right? Insurance policies that encouraged you to take care of yourself, gave you discounts when you exercised, and actually maybe insurance policies that actually tracked your fitness monitors, that actually encouraged you to wear them. I know privacy concerns. I don't care about privacy. If I'm going to get a discount, I want my insurance company to know how much I exercise. And maybe, you could even take photos of what you eat. I don't know. But the point is, you'd get innovation. You'd get competition. And you'd get real insurance. And you'd get insurance that does its job. If it was good insurance, it would do its job to lower your risk of actually incurring the catastrophic risk, right? So, fire insurance, the insurance company might come to the house. They certainly do this with big expenses like industrial insurance, and say, look, we would actually lower your cost of insurance if you did these 5 things to make your home more fireproof. For example, I remember we changed the type of tiling on our roof and the kind of insulation in our attic that actually lowered our cost of home insurance. Why? Because the house was less likely to burn down. Well, imagine again that insurance companies were willing to lower your health insurance because let's even say you're taking a statin that lowers your ApoB to a level that makes it very unlikely that you will get a heart attack. And the insurance company might say, we'll even, now it turns out that statins cost almost nothing, but some of these other mechanisms to lower cholesterol are quite expensive. The insurance company might even say, yeah, we'll cover that cost because, because we're going to have you as a client for many years, and it lowers the chances of you actually needing this catastrophic. I don't know. My point is, you'd get innovative products. Hospitals might provide insurance. Doctors' associations might provide different types of insurance. I mean, we might be able to move into what Peter Attia calls healthcare 3.0, which is a healthcare much more focused on prevention than on treatment. And to fund and that orients everybody and everything and the incentives, both of the doctors and of the customers, towards prevention rather than towards just treating you when you're sick. So once we get the employers out of it and we get individuals to buy their own policies and we provide them with an incentive to put money aside for their health care through a tax deduction, MSA, medical saving accounts, and an incentive to buy some kind of insurance, but any kind of insurance, you've solved a huge part of the American healthcare system. And then I am buying healthcare. I'm going to my doctor and saying, okay, how much does it cost to fuse my back if I need back fusion? What are the alternatives? How much do they cost? What are the outcomes? All right, let's sit down and figure out what I should do. What is insurance going to cover? Will insurance cover any of it? And if so, what of it will it cover? Given its catastrophic nature, does this count? All of that would then go into decision making. Now, this requires people to actually be engaged, to be involved. Or, just like, it could be that just like we have financial advisors where we say, I don't want to think about how to invest my money. It's too difficult. I'm going to hire somebody. I'm going to do my research and hire the best person I can. And then basically they're going to invest my money and they're going to determine how it's going to be invested. Maybe we have healthcare consultants, healthcare advisors, who, when we have healthcare decisions that are really complex and time consuming, we hire them to come in and provide us with all the facts and help us make the right decisions. I don't know. That's the beauty of markets. Whenever there are asymmetries of information, and they're huge in Medicare, healthcare, no question. Whole sectors of the economy develop, new professions develop in order to mitigate the asymmetry. So one can only imagine the kind of products, the kind of innovations that would happen to deal with the complexities of healthcare. And maybe that consultant is simply our physician, our general physician. Maybe that's generally part of their role, is to help us navigate. It's to organize what specialists are saying, and it's to sit down with us and say, okay, here are the options, and here's what's possible. And maybe, and one would expect, given that I am paying, that they would start treating me a lot better, spending more time with me, and that the general physician would become much more of a consultant, coordinating all aspects of my care with specialists and hospitals and clinics than just a guy I go see for a general checkup and go to get a couple of aspirins when I'm not feeling well. So imagine your primary care physician becoming that, a real consultant to you, somebody who is really there to work with you through a healthcare plan, how to avoid disease, how to stay healthy, and then when something does happen, how to maneuver, how to deal with the complexities of the system. All right, so we phase out. You got to phase out and you got to do it over time. You can't do it all at once. I would start by offering MSAs to everybody, and then I would basically put a sunset a year from now on the tax deductibility of health costs. So first, offer them MSAs. First, give everybody an opportunity to open a medical saving account. Then tell employers, you're not going to get the tax deduction anymore. Not going to get the tax deduction anymore. You've got a year, 2 years to adjust, to adapt, and to educate your employees to the fact that, you know, they will get a better deal if they buy insurance through the MSA, through the medical saving account. And what will happen is you'll get insurance markets developing, you know, a little bit like Obamacare, but better, more efficient. We'll get to Obamacare later. But so a vast majority of working adults get their healthcare today through the employers. That would go away, and they'd start getting it personally, and a big chunk of the healthcare system would suddenly be privatized. Now, if you couple that with real deregulation of hospitals, real deregulation of doctors, real deregulation starting of drugs, massive benefits. But you still need a deal with Medicaid and Medicare. And this is not easy because they're so big. And so many people depend on it. So many people are being conditioned to depend on it. You can't just take it away tomorrow. Everybody has pre-existing conditions. It would be very, very difficult for them to fund it. People have not saved for their health care when they're old. So let's start with Medicare. So I think Medicare needs to be phased out. It needs to be phased out over time. And it might take a generation to phase it out completely. The best idea I've seen around phasing out Medicare is to move Medicare away from healthcare, to make it purely a system that subsidizes health insurance. So Medicare should stop writing checks to hospitals for drugs, for anything. Medicare should move to basically a voucher system. A voucher system that allows the elderly, anybody over 65, to buy healthcare and to buy catastrophic insurance. So basically, take what we spend today per person on Medicare, have them all open up medical saving accounts, and put the money into the medical saving account. The government literally puts the money into their saving account. And they can use that money to buy insurance and to pay for healthcare spending that they might have. This is going to be incredibly expensive, but Medicare is already incredibly expensive, so it would stay expensive. But what you would do is every year, every 2 years, the amount of money that went into this medical saving accounts would be slightly lower for new people entering the system. So for old people, you would guarantee, I'm just making numbers up now, you'd guarantee every year you get $10,000 or you get $1,000 or whatever it is, you get it every year until you die into the medical saving account. For anybody 65 or older today, if you're 63, when you turn 65, you'll only get $9,000. If you're 61, when you turn 65, you'll only get $8,000. And so on. So the young people can look at it and say, okay, the government's going to give me a lot less money. So, but I have more time to prepare for that. And part of that preparation is going to be, I'm going to save more money in my medical saving account for when I probably most need it, in my 60s and 70s. So I'm going to start accumulating money in my medical saving accounts. I'm going to start saving. And I'm going to keep this private insurance. I'm going to get policies that will cover me when I'm in my 60s and 70s. So the subsidy, whatever the amount is per senior, we keep, in a sense, the promise to the people today who are retiring or 65 and older. But anybody entering the system is going to get less. Now, how much less? You'd have to do the math. You'd have to figure it out. You'd have to see how the markets evolve, too. I mean, it could be the insurance prices go down quite a bit. And healthcare costs could go down quite a bit now that we're creating a real market for insurance. A real market for insurance and a real market for healthcare. And now we're creating consumers for healthcare. Real demand. Not demand by big entities negotiating, but by individuals. You'd expect healthcare costs to come down. And you'd expect the whole industry to focus on profitability and making themselves profitable by reducing costs. So prices come down through competition and through innovation. Now, I think you would do the same thing with Medicaid. I think for every poor person, however you categorized it, you would open up a medical saving account and you would say, we will fill it up, depending on how poor you are, up to a certain amount. And again, we are going to phase this program out. This is not permanent. We're going to phase this program. Although, even if it was permanent, it would be far better than what we do today. And notice what happens now. Now you've got insurance companies competing for their dollars. You've got insurance companies competing for the Medicaid and Medicare recipients' dollars. Because they're still offering them through the market products, catastrophic primarily products. But now you've got doctors and hospitals competing for their dollars. Rather than negotiating with this massive Medicare or Medicaid, now they're negotiating with real customers who are price sensitive. So, I rather you subsidize generally and eliminate all regulations than regulate and become a direct purchaser. So it's better if the government just subsidizes in a sense that provides a cash benefit to people. And in this sense, I have some sympathy for the universal basic income. If you could guarantee to me that you're willing to get rid of every single welfare and healthcare and education dollar spent by state, local, and federal government, every dollar spent on welfare, but also on healthcare and education, every dollar spent, then I think a universal basic income would make a lot of sense. Basically, what this voucher system is moving us towards, that. Giving them the money so they can buy it. And then start phasing it out. So have a universal basic income. Let's say universal basic income says everybody gets $15,000 a year. I'm just making that up. And then every year it goes down by 1,000. So that in 15 years there's nothing and the welfare state is zeroed out. Or maybe you think that's too quick and every year it goes down by 500. And within 30 years it's zeroed out. It's fine by me as well. And the same here. Ultimately, the poor should get nothing from government to buy health insurance or to cover their health expenses. And to a large extent, capitalism would eradicate poverty. That is, the whole goal should be to grow the economy so fast that in absolute terms, nobody is poor. And for the freak event where somebody really can't afford it, that's what charity is for. And the same thing with old people. People should be incentivized to be responsible and to save. Save money for old age. And if they can't, or if they don't, because everybody can, then charity will have to take care of them. But I get it that you can't advocate for that today. That is long term. That is in 15 years when we phased out all these programs, or 30 years when we phased it all out. And this, of course, brings you to Medicare, Obamacare. Obamacare, if we phase out Medicaid and phase out Medicare and we move all insurance to individual insurance, Obamacare goes away. There's no reason to subsidize exchanges. You're already, in a sense, subsidizing the individual to buy the health care. They're either Medicaid or, and insurance costs, because the insurance market is deregulated. The insurance costs are going down, and there's just everybody can afford insurance. And those people who are really too poor to afford real insurance being catastrophic insurance, you're basically giving them a subsidy. So today, Obamacare subsidizes people who are not in Medicaid, but who don't have enough money to buy insurance. But that's because insurance is so expensive today, because it covers so much. It's so heavily regulated, and it's not real insurance. It's a risk pool. But if insurance becomes real, just catastrophic, and if everybody can have an MSA, and they can start saving, even if it's a little bit of money, for the annual doctor visit, for the getting a flu or getting something like that, you take away the need for the additional subsidies on top of Medicaid and Medicare that Obamacare requires. And now you just have a real marketplace in insurance. But then it becomes real insurance, i.e., for catastrophic, rare, unpredictable events. And the rest you save for. So again, I'm advocating for UBI to be phased out as a step towards getting rid of the welfare state. So you're not going to get rid of the welfare state without some kind of transition. You're not going to get rid of the welfare state like that. The best way to phase it all out, you could phase out Medicare, Medicaid. You can phase out, and by the way, one thing you could do with Medicare is the voucher system could be means tested. Right? The voucher system can be done in a way that, and this reduces cost dramatically. Not everybody gets it. So it's like Medicaid. If you need it, you get it. If you don't need it, if you can afford the health insurance costs and your health expenditures, then you don't get it. So you can come up with a way in which the annual expenditures is already going down dramatically. And yeah, that makes it, it's now mean tested, but I paid all my life taxes for Medicare. You just pay taxes. We all just pay taxes. It's not going to any particular thing. It's all fungible. Social Security is fungible. Medicare is fungible. And indeed, most people spend 4 times more than they ever paid into. So all of these things need to be phased out. The idea that you can get rid of them all in a bang, it's never going to fly. It's not doable. Maybe in a horrific crisis, but then you don't want to live through that. So you phase it out. So UBI only as a means to phasing out the welfare state. All right, I'll just add that part of the massive deregulation would dramatically involve FDA reform and ultimately the privatization of the FDA. The first step of FDA reform could be the FDA approves drugs only on the basis of safety, not efficacy. And then, a market will evolve for different labs that evaluate efficacy. And then you can basically get rid of the safety issues around the FDA as well and privatize those. So ultimately, you want all drug development approval to be private. And here, you've got to reform the way drug development is done. We've got to reform the way science is done, the way grants are given. That's a whole other topic. We can do another time. But ultimately, you want the government out of that as well. But again, all of these things involve phasing out over time. You're not going to get a government that is going to just drive everything down to zero. I mean, you want the FDA out of recommending food. You want them out of food inspection. You want them out of the whole gamut of what they do. But in healthcare, what you want is to reform so that you can get more drugs onto the market and then privatize. Reform and privatize. Okay. Now, note that if you do all this, wages will go up quite a bit because, employers who now do not have to buy you health insurance will be able to give you that money as salary. That is money that can immediately go into your medical saving account. So wages go up as a consequence of all this. As government spends less on healthcare because it's phasing out Medicare and Medicaid and making Medicare means tested, as all of that is being phased out, the government is spending less money and hopefully taxes come down. At the same time, health outcomes improve dramatically. There's more innovation in the system. There's more doctor and generally producer involvement in the system. Hospitals start caring about you. Doctors start caring about you. Not that they don't care now, but they have an incentive to provide great service because you are the one paying them. Doctors become more engaged in potentially alternative solutions, more interested in finding alternative means to solve problems. They become much more engaged in problem solving than just being bureaucrats. They become engaged, involved, and responsible for your health together with you. So the whole system shifts. It becomes dynamic, interesting, exciting. And again, particularly if we get the shift to what Atiyah calls 3.0, where the doctor now becomes your consultant on staying healthy, it can become fun, experimental. It becomes something that even as a consumer, you embrace and look forward to versus going to the doctor. Now, when you go, it's typically because you're sick. Imagine going to the doctor in order to stay healthy, in order to stay fit. You would see, new drugs on the market, new medical techniques, new medical devices, new procedures, and a general orientation towards health, a general orientation towards staying healthy, rather than the orientation of just, solving problems when the problem already exists and when solutions are limited. I think you'd see a lot more medical trials. I think particularly if we reform the way medical trials are done, which I think needs to be done in dramatic fashion, a lot more medical trials, a lot more experimentation. I mean, we are, I believe, on the cusp potentially of just a revolution in not just prevention, which I think, again, people like Atiyah are leading, but of treatment. Whether it's vaccines against cancer, immunotherapeutic, all kinds of immunotherapies, where we teach our body or train our body or induce our body to fight the cancer, which is what the vaccines do, or whether it's new massive amounts of new drugs in the pipeline to treat autoimmune diseases, which could be major revolutions. Major revolutions. So, again, we could see life expectancy, but more importantly, the quality of life dramatically improve. Now, and I want to say this, I think it's important to say this to finish off. In spite of all the problems our medical system has today, and it has big ones, particularly when you think about the potential and what could be, and how long we could live, and how well we could live. What is truly amazing, and this is a testament to the heroism and the dedication of doctors and researchers and scientists and pharmaceutical industry, why I hate the attacks on pharma. What is truly amazing is how much gets done, how much innovation is indeed happening. As I said, the American healthcare system, if you are sick, there's no better system in the world to be under. If you take away the stupid lifestyle choices that Americans make, and if you just look at outcomes, if you get cancer, which healthcare system would you rather be in? It's not even close. You'd rather be in the US. If you get heart disease, which healthcare system would you rather be in? Now, so we have an amazing healthcare system. And if we make it, and if we make these changes, we can have just an unbelievably amazing healthcare system. A healthcare system, I think, that could be better, in extending our lives, but more importantly, in improving the quality of our lives than anything we can imagine today. Anything we can imagine today. So it's I think it's super exciting. I think the potential is super exciting. The depressing part is that these things are very unpopular and almost impossible to get through. And there's no energy, there's no passion, there's no real drive to get big time healthcare reform done, particularly not dramatic reform like I've articulated here. There's too much of this idea that's now become inculcated in people's minds that healthcare is a right, which is, I think, the biggest barrier to this, and therefore must be supplied by the government. Healthcare is a right in the sense that you have a right to go out and seek whatever treatment you want, as long as you're willing to pay for it, and as long as the provider is willing to provide it to you. All right. Yeah, hopefully that was useful, helpful, informative. Again, this idea of if we could just get medical saving accounts for everybody, that would be a huge leap forward. And there was work done on that, and some of it led by objectivists 10, 15, 20 years ago. But it never took off, partially because of massive regulations and partially because MSAs were always limited, always constrained, and partially because it's hard to compete with employers who can just provide this. The employer tax deductibility has to be eliminated. It has to be phased out. All right. Thank you, guys. So we can go to our Super Chatters. We've got a lot of questions here, and we've done really well on Super Chat, primarily because Wes came in with $500. Wes, thank you, thank you, thank you. That is fantastic. We're about $58 short of where we need to be to get to our $750, which is the goal for a 3-hour show, and it's likely, given the number of questions, that we'll at least enter into the third hour. But we will see. Actually, not that many questions, so maybe not. But anyway, we're doing great. So thank you. Let's see. What do I want to remind you of? I want to remind you of that you can become a monthly supporter of the show by going to patreon.com and putting on the Yaron Brook Show. And I hugely value that. It's where most of the money comes for the show is from PayPal and Patreon, and it's what keeps the show going. And, you can express your values that way. And that way, if you're listening on a podcast, if you sometimes are live, sometimes not, doing a super chat sometimes not, that way you know that you are trading value for value by supporting the show. And at $10 a month or more, you get to listen to the podcast ad-free with no advertising. And you can listen to the podcast on any podcast app you want, ad-free, if you go do it through Patreon and $10 for $10 or more. I also want to remind you that we have two sponsors, Alex Epstein, alexepstein.substack.com. Alex provides the best talking points, the best information, the best knowledge about what's going on in energy in environmentalism and climate change that you will find anywhere. So check out alexepstein.substack.com. Check out his talking points. You can also check out his Alex AI for information about this. Make yourself better educated and more importantly, or not more importantly, as importantly, a better communicator of what you know about these topics with the help of Alex, the world's expert on these things. And then the Ayn Rand Institute is looking for people who would like to come to Austin, Texas for a weekend in-depth study of objectivism with people like professors like Greg Salmieri and Ben Baer and others who will take you deep into the philosophy of objectivism. You'll be there with other students. It'll be a blast, particularly people who have an interest in becoming maybe, not even for sure, but maybe intellectuals one day, professional intellectuals one day. You should consider Austin, Texas, late February, a weekend conference, all expenses paid. But to do that, you have to apply for scholarship. To apply for scholarship, go to aynrand.org/start here. aynrand.org/start here. All right, so let's look at our super chat and cover that and see where we go from there. We will start with Wes, $500. Really, really appreciate it, Wes. A regular, ongoing super chat supporter of the Yaron Brook show, and just steady, regular, amazing. And then, once in a while, a big chunk like $500 that is, it really motivates me to do shows like this, that not only do we have sponsors for, but we also then have somebody like Wes willing to put a lot of money in for it. It's not going to get, a show like this is not going to get the most views. My immigration to China shows did not get the most views because people like the newsy stuff. They like the controversial stuff. And they're not interested in the solutions necessarily. They're interested in the angst, in the controversy, in the bash the left kind of stuff, or bash Trump kind of stuff. So I appreciate it when I do a show focused on solutions, focused on potential solutions, that it gets so much support. All right, Wes says, I'm a data analyst that has worked with some of the largest healthcare systems in the country. The whole system is so convoluted. I can say that almost no one knows how hospitals actually make money, including the people who work in the industry. Yes, I mean, basically hospitals make money by charging more than they spend. But here's the thing. A lot of times hospital will lose money on their Medicaid patients and then make money on their private insurance patients. And in some cases, they might lose money on some procedures and make money on other procedures. And the whole thing is convoluted by the fact that there's no pricing transparency, because the customer don't care about prices. So hospitals come up with all these, they're required by law to have prices for everything. So they basically have prices that are ridiculous. I heard $16 a gauze patch, right? Now, nobody actually pays $16 for the gauze, but that's the price that the hospital lists. I guess you pay the $16 gauze if you go in and say, I'll pay cash, and you don't negotiate with them, then maybe you'll pay the $16. But that's because why not have the highest prices possible on your website, and then kind of not on your website, but because they don't do it on their website, but has on their price sheet. And then they sit down with the insurance companies and they negotiate down from that. And a lot of it, the way it's paid is not paid by item, but paid by procedure, and therefore it includes all the things that go into the procedure. So bypass surgery, all the hardware involved in a bypass surgery is going to be paid in bulk. There's a price for that, and then the doctor gets paid, and the staff gets paid. Do you know how much a doctor gets per bypass surgery? Something like between $1,000 to $2,000. That's how much he's reimbursed by the insurance company for bypass surgery. And you'd think it would be a lot more than that, right? Given, I want to pay the guy who's opening me up and playing around inside of me with my heart. I want to pay him a lot of money. I want him to get a lot of money because I want him to do a good job. But they do a lot of them, so they make a lot of money at the end. But and $1,000 might, $2,000 might include all the meetings you had before and all the post-op meetings you have with them. It's pretty amazing how cheap it really is. So the pricing, so they have a whole thing where they negotiate with insurance companies. So when you go into the hospital, so when I was in hospital, I got a bill from the hospital, even though I wasn't paying. I didn't care. And it was like absurd. It was like $500,000. I was in the hospital for like 5-6 days. I think 6 days. $500,000. And I think the insurance companies maybe paid $150,000. And given what was done to me, and given the service I got and given everything else, it's not a lot of money, I don't think, for the 5 days, 6 days. I had back surgery, but it was complicated back surgery, and it took for hours and hours and hours. And I don't know how much the doctor got for it. I hope he got a lot of money because he spent the whole day just on me. Like, it was a 9-hour surgery. And then he had to go back in 2 days later for another 4 hours, I think. I mean, that's a lot of time. I mean, I hope he got paid a lot of money for it. Probably not. So anyway, there's a convoluted way in which that's paid. And then Medicare sits down with hospitals and says, this is how much we're willing to pay. And sometimes Medicare probably overpays. Sometimes it underpays. And the hospital has to take into account what Medicare is paying them in order to figure out how much they can afford of a discount to give the private insurance companies. And the same thing with drug prices. Drug prices are listed at these incredible rates, but then the insurance companies get discounts, and the pharmacies get discounts, and individuals get discounts. And I don't know, a lot of drugs I see out there in the market are, you know, the ones that are popular and maybe out of patent are unbelievably cheap. $1 a pill, less than $1 a pill. Sometimes you just get them for free. The insurance is covering all of it. I mean, it's just bizarre. And so price becomes, it becomes meaningless. Instead of private individuals actually seeing a price, choosing partially based on price, you know, paying their doctor directly. And the insurance stepping in with only, you know, the real massive amounts. You had to go to hospital you didn't expect. The $100,000, the $1 million cancer treatment, stuff like that is where the insurance companies and they are fine with it because they priced it as catastrophic. They know, and then there's less denial of coverage because it's understood what the insurance is for. So yeah, it's unbelievably convoluted, unbelievably complex, because it's trying to do what cannot be done, which is, you know, have a third-party allocator fund all these things that it shouldn't be funding. You're trying to fit into an insurance model something that's clearly not insurance. And that just makes no sense, and it provides all the wrong incentives to individuals. Thank you, Wes. All right, Andrew, $50. Any honest economist knows that free markets lower prices and increase quality. Yet mainstream intellectuals are quoting Rand practically catatonic when it comes to capitalism. Healthcare is too important to be left to markets, they say. What say you? Well, I mean, healthcare is too important not to be left to markets. The same with education, the same with everything. You know, government is force. Government is coercion and a gun. Coercion and a gun have no room in the doctor's office. They have no place in the operating room. They have no place in drug development. So what you want are markets. Now, Well, markets always lower costs. I mean, yeah, for equal quality, but quality might go up and cost might increase. And the point about healthcare being expensive is for whom? Like, I get it that Medicare and Medicaid are unsustainable, and they are unsustainable. But, you know, is healthcare, how much of your budget as an individual would you be willing to spend on healthcare? You know, a lot. What percentage of your lifetime income are you willing to spend to be healthy? I don't know. Some people spend, and I don't think this is outrageous, 25% of their income to stay healthy and to treat diseases when they crop up. Is that unreasonable? Other people spend a fraction of that. But what's the right number? Well, only the individual can decide what the right number to spend on healthcare. So healthcare is not expensive. 17.6% of GDP. Is that a lot? I don't know. Is it a lot? I don't know. That's not what troubles me. It's not troubles me if 20% of GDP is spent on healthcare. That doesn't worry me. What worries me is that government is spending it and it has no means by which to pay it off other than to, you know, and all it's doing when government is spending it is redistributing wealth, which I think is evil and wrong and on top of being evil and wrong and immoral, inefficient. So what I want is a system that gets rid of redistribution, gets rid of the cross-subsidization. Now, again, you can't do that all at once, so you're going to have to subsidize over time in order to get rid of the subsidies ultimately. But the worst kind of subsidies, and this is, I think, an important point generally, the worst kind of subsidies are the hidden subsidies. Explicit, out there, here it is. You know, every electric car you buy, the government gives you a $2,000 check. All right, we get that. We might not like it, but we get it. But when the subsidies involve, well, we're going to actually subsidize the battery, and we're going to subsidize the development of whatever. If you look at EV subsidies, for example, 90% of the subsidies are hidden. You never see them. What you see is just the tax advantage that the government gives you to buy an EV, but that's not the main subsidy. The main subsidy is all kind of little things that are inside there. Those are the ones that do the real damage, because those we don't even know exist. So get rid of those, and then we can phase out the known subsidies. So Medicare, Medicaid, huge subsidies, super inefficient subsidies, super distortive subsidies because they distort the whole market for healthcare. By voucherizing them, you still subsidize. But now the subsidy is explicit. Everybody knows how much it costs per person. And those vouchers are used in a private economy in a less distortive way. Now the supply side of healthcare responds to demand directly, not through some government entity or through some kind of employer-provided third-party payer, but directly. And again, then you have a means also to phase it out. You have a means to get rid of it. That is, you just reduce the subsidy every year. You make it smaller. All right, thank you, Andrew. All right, John. Are you familiar with former Rand fan John Goodman, whose Policy Institute promotes healthcare reform? Yes, I think it's in Dallas. I know John. We've talked periodically over the years. He's quite good on certain things. You know, unfortunately he's abandoned Ayn Rand a long time ago, and is a little too forgiving of government intervention in the economy, government intervention in healthcare. Too moderate when it comes to that. Some of you might consider me too moderate in my reform proposals, but he's even more moderate than me. But on the other hand, has a deep understanding of the field, often has interesting solutions to particular problems, and is one of the people working towards making healthcare freer, and I give him credit for that. And we need a lot more think tanks, institutes that are dedicated to things like that. There are a number of good free market healthcare institute. The one run by objectivists is AFCAM. I mispronounced its name last time. It was Americans for Freedom of Choice in Medicine, I think. Americans for Freedom of Choice in Medicine. Somebody correct me in the chat if I'm wrong. They're an objectivist-run organization. Amy Shadal's just part of it. We've got one of our scholars at the Ayn Rand Institute is running it these days. Ray Shore. And yeah, I mean, it's going to be exciting as Ray ramps up what they do to see how they start trying to influence the healthcare system. We will have somebody from AFCAM on the show later this month. They will be sponsoring a show to talk about their approach to privatizing healthcare, to fixing healthcare in the United States. So you'll get the perspective of doctors and physicians and people in the field rather than my perspective, which is as an economist inspired by philosophy. Jason, Europe would have us believe you have the public mandate insurance, 8% of income, but you can go to a private doctor and pay out of pocket, and it is still far more affordable than the United States, granted, not the Mayo Clinic. So I don't think that's true. It's probably true of a lot of day-to-day stuff. I don't think it's true when it comes to big items, heart disease, cancer, autoimmune diseases, Alzheimer's. I just don't think that's true. But look, what Europe does is Europe basically places, restricts supply. It places constraints on supply. And therefore, that is a way for them, and they do that with price controls. That is a way for them so they ration. Europe and socialized medicine generally is a rationing mechanism. And that's how they keep prices under control. And so it's cheap in the system because it's a ration system, because suppliers will only provide so much at those prices. So I guess you can go to a doctor and get stuff on top of that. I haven't run the numbers. I don't know what it would cost. And it could be, I mean, our employer-based insurance system is very, very, very expensive. Partially for the reasons Wes said. It's so convoluted that nobody knows what anything costs. And there's a huge amount of waste, and there's a massive amount of bureaucracy. And the reality is that there is a sense in which, like, the NHS has less bureaucracy than the American healthcare system because it's so convoluted. Single payer is simpler. You want an MRI? Fine. Stand in the queue. But it's simpler in the sense that we don't have to negotiate prices. We don't have to monitor which MRI you got. You just stand in the queue and you get the MRI like everybody else's MRI. You don't have any choices. So if you reduce choice, you can reduce cost. Now, the private sector in these systems is typically very small, particularly in the UK, and you can't get the major procedures there. You can't get major surgery. You can't get the treatment under the major stuff. Socialized medicine eliminates choice. That's the one thing it eliminates. And it constrains supply. So it rations. So the choice you have is rationed. Alexa says on the chat, 7-hour wait in ER, emergency room, in central London hospital for an allergic reaction. Now, You can get long waits in the US as well, but that's because we have regulations, for example, that force hospitals, emergency rooms, to treat anybody who walks into an emergency room. Anybody. Whether they have insurance, they don't, whether they can pay, whether they can't, whether they have a heart attack or whether they have the flu. And that creates bottlenecks. And then that turns it into a European-like emergency room. But if you basically said, yeah, we're not treating flu patients, we'll only treat who we want to treat, it's an emergency room, then you would have a very different emergency room experience. All right, thank you, Jason. Jennifer, my dad and yours were doctors. People have no idea how hard they work to get there. It makes me so sad, so mad, when people think they know medicine when they never studied or practiced it. Yeah, I mean, you see it all the time. We've got amateur doctors everywhere, experts in the field of vaccines, immunization, diets, everything, and heart disease and cancer, and they know exactly the causes and the cures and everything. It's ridiculous. But it's not just how hard they work to get there, it's how hard they work as doctors. At least, now my father worked mostly under a socialized medicine system in Israel. But he had to make a living because he got paid by the government, and the government paid doctors very little. So he then had to have a private practice on the side. So that was in the evenings. And, so he worked all day, taught at a medical school, ran a department at the hospital, and then in the evening, had a private practice. So we never saw him as kids. He just worked. Barbara, illustration. Had a knee replacement last year in Europe using private pay. Total cost, including 5 days in hospital, was 10,000 euro. In the US, the cost is 100,000 euro or more. And patients are sent home the day of surgery. Yeah, absolutely. I mean, I had back surgery in the US, right? Outpatient. I was sent home within hours, which I like. I don't want to spend the time in hospital. I don't like spending time in hospital. You shouldn't have to be 5 days in hospital for a knee replacement. And I didn't pay anything. I don't know how much it cost the insurance company. I have no idea. It wasn't 100,000 because it was outpatient. It was probably 10,000. But I got out of it. And the only reason it cost me, and this is the beauty of the American system, and maybe you can, and I think you can do this in parts of Europe, not everywhere though, is I convinced my doctor to inject me with stem cells, to inject the disc that he was cleaning up with stem cells. And for that, I had to pay him cash. So I think that was $5,000 that I paid cash. He basically had to get a machine and to spin the stem cells. He has to go into my hip and extract bone marrow and then spin it and then inject my stem cells back in. And so the whole thing cost me out of pocket $5,000 because I paid nothing for the rest of the surgery. That was all covered by the so-called insurance that I had. I've spent time in hospital. When I got my fusion, I had back fusion. That was before that, more than 10 years ago. And there I spent 6 days in hospital. 2 surgeries, one of them a full day, a whole day. Knee replacement is not a full... and it cost me nothing. Now, I don't know how much it cost my insurance company. That's part of the problem. So it could be that in Europe, if you use the private system, it's ultimately cheaper. I don't know. I mean, I have health insurance in the US. It covers a lot. All my surgeries are paid for with private doctors in private setting that I choose. My back surgeries were doctors I chose. One I stayed in hospital, one I didn't. I just had shoulder surgery here in Puerto Rico. The same day, in and out of the hospital. I chose the doctor. I could have gone to the U.S. I could have chosen any doctor in the U.S. to do the same surgery. I didn't want to because I wanted to be, if there was complications or anything like that, I wanted to be close to the doctor. I didn't want to have to fly to see the doctor. But I could have chosen any doctor in the United States to do the procedure. It would have cost me the same here as it would have if I'd gone to the Mayo Clinic to have it done. Zero. So I am, you could argue, I'm super happy with kind of the direct costs and healthcare that I get because I get to choose my doctors. What I'm not happy about is what I know is possible in a proper privatized healthcare system. What's missing is the innovation, the dynamism, and I pay a lot of money for insurance. I personally, it's not through a business, and I pay a lot of money for insurance because, again, I'm subsidizing Medicare. I'm subsidizing I'm probably subsidizing the employer-based system. I'm not getting a tax deduction on it. So, there's a huge subsidization, cross-subsidization going on here from me to other people that I'm not happy about. And again, I'm not happy about the fact that it could be so much better. But I believe that today I get the best healthcare in the world. And for me, in terms of my expenses on healthcare, probably about as cheap as it gets. I mean, I wish it was different because I think I can imagine what else could be, but I wouldn't want to be in Europe. And I appreciate what you're saying, Barbara. But yeah, and I think that if you can get, if you can be in a private healthcare system I think like the Swiss system is really good, and there may be other systems that are really good. I would never want to be in the UK, even with private healthcare. I wouldn't, even with the potential for private insurance. I wouldn't want to be in a lot of these socialized medicine countries. I think Switzerland is unique because it has a private sector adjacent to it. It's also relatively less regulated. You can do a lot of procedures in Switzerland you can't get here in the US. There's a lot of stuff you can do with stem cells in Switzerland, but also in South America that you can't do in the US. So imagine if we got rid of all those regulations and all those controls. Yield 25. Can you recommend any good articles or books that discuss healthcare in the way you just did or smaller? God, I don't know. I mean, John Goodman, I think. Look, John Goodman for books on healthcare. I can't remember now. I've read some in the past. There were some good books on medical saving accounts. But no, I don't have off the cuff books. But look for books on medical saving accounts, privatizing healthcare. There are some good books by Cato people, by John Goodman's Institute. There's an institute in San Francisco. I forget the woman's name that's written some good books on this. So there is material out there. Alexis, what is the common thread between finance and healthcare that made them prime targets for the intellectual status, assuming you accept that premise? Fear, asymmetric information. You always get that. You'll be taken advantage of by the financier if they don't have to register at the SEC and they don't have to jump through all these hoops. We need to license these people because otherwise they'll cheat you out of your money. They'll commit fraud. We need to make sure they're good people. So asymmetric information in both. You've got experts who know a lot more than you do. I mean, that's true of everything in life. That's the beauty of a society of division of labor and specialization. But finance and medicine, I think, are particularly so, and everybody appreciates that. Wow, yes, specialized knowledge is really needed there. That's one. Regulation of them evolved completely differently. finance was regulated from the beginning of time because it was viewed as exploitative from the beginning of time because of the attitude towards usury, the fear of great financial power, the fear of wealth associated with finance that doesn't exist in healthcare. So other than the asymmetric information and the view that we're too stupid to take care of ourselves, which involves both, the fear that greed, i.e. profit motive, will cause real harm exists in both. Other than that, I think they're quite different. Healthcare evolved in a particular way, and nobody thinks you have a right to a saving account, but you have a right to healthcare. And that makes it even more difficult to separate healthcare from government than it is finance from government. You're right, they're both emotionally charged, but they're mostly charged because on the healthcare side, it's viewed as a need, and on the finance side, it's fear of being exploited. I think it's emotionally charged for different reasons. Certainly, altruism dominates the healthcare. I'm not sure it's as dominant in the finance. It's there, but it's not as dominant. All right, Andrew. Republicans don't have the moral base from which to be serious about challenging how healthcare works in any fundamental way. Ultimately, they agree with mass collectivization of healthcare. Yes, and you saw that by the inability to repeal Obamacare, by the inability to repeal Medicare and Medicaid. I mean, go back to 1964, the election of 1964, and the speeches that Ronald Reagan gave in 1964 against Medicare. They're brilliant. They're really good. Really, really good speeches. He makes a lot of good arguments. But once it was passed, nobody stood up against it. No Republican ever talked about downsizing it, never mind reforming it, never mind eliminating it. All they've done is expand it. The expansion of Medicare has happened under Republicans, primarily under George Bush, 2002, 3, something like that. So yeah, there's nothing. They never undo any socialist program that's already put in place because they basically accept the moral premise under which it exists. Andrew, people have no idea how good healthcare would be under capitalism. It really is the unknown ideal. Thanks for making it a little bit more known. Yeah, it really is an unknown ideal in the sense that you can't imagine the technologies, the drugs, the knowledge, the help, the suggestions, that would be available under a free market healthcare system. Working to allow us to live longer and healthier while we're at it. I mean, the experimentation, the innovation, just hard to believe. Hard to imagine, not hard to believe. Very believable, just hard to imagine what it... Cook says, solving U.S. healthcare is easy. You just gotta outlaw the profit motive. Then plenty of medicines and healthcare will magically appear for everyone. That's it. It's the profit motive. It's the exact opposite. I mean, what Cook is saying, it's the exact opposite. What we need to do is reinvigorate the profit motive. Reestablish the profit motive of every aspect of healthcare. We need to expand the profit motive to touch every little bit of healthcare. Enric says, should HIPAA be scrapped and let patients choose how their information is used? So much repetition of data for every doctor and visit. Yes. If HIPAA was scrapped, I think you'd get a lot more innovation in digital analysis, digital storing, digital integration of healthcare information. And HIPAA makes no sense. I mean, you want a law that says the patient should be able to decide what is done with its information unless, the patient should decide, including not caring and giving it all to you. And that's it. That's all you want, is a law that says the information belongs to the patient. Other than that, you need nothing else. HIPAA is just another creation, another huge bureaucracy that slows down our progress. Rafael, in a country with NHS, how would you go from NHS to MSAs in a free market healthcare system? I mean, it would be a lot more difficult. It's a lot more entrenched. How would you do it? You would basically have to phase it out. Again, you would have to create some kind of means testing. So you would start with, I think, okay, if you make more than £100,000 a year, the NHS is not for you. And that's going to start a year from now. You can't start it immediately. That's going to start a year from now. That creates an incentive now for hospitals to be built, clinics to open, doctors and insurance companies to come about. You'd also have to, I mean, immigration policy is really important. You have to be able to adjust the supply of doctors to the new demand. But a year from now, anybody making over £100,000 gets no NHS. Zero. And maybe it has to be more than a year because you have to build hospitals. These are the kind of factors that have to be put in, because I don't know how many private hospitals there are, how many private clinics. Maybe it has to be 2 years. Maybe you start with £500,000 sterling, and then you slowly decrease it to 100 and then to zero ultimately. So you phase it out. You say, who are the people who really, really, really depend today on NHS? It's the poor. It's people who couldn't afford insurance even if it was available. And of course, by doing that, you make it possible to cut taxes and to free up people's resources so they can spend it on healthcare, which is really, really important. Barbara, I'm glad you brought up the universal basic income. I'm okay with that as well, at least as a temporary program. I think the money saved on administrative costs would more than fund a reasonable AMT. I don't know. I'm not sure what that says. Anyway, I would only support it, again, if it did the following. Every single other welfare and redistributive program has to be eliminated, including Medicare, Medicaid, and education, right? And then you introduce it. So all of that would have to be eliminated, and that's a lot. And then I would say it has to be phased out. It can't stay at the high level, because the whole point is to incentivize markets to develop and then slowly get the government out of it, and at the same time cut taxes. So, yeah, universal basic income. Okay. Barbara says, no means testing. Higher administrative costs would eat up the savings. Means testing does not have to involve high administrative costs if you make it very, very simple and very, very easy. But yes, for the UBI, there should be no means testing. If it's $10,000 or $15,000, everybody just gets a check. And you could roughly means test it by saying, okay, if you make over $250,000, you don't get the check. I think something like that, some very high number, and then your bureaucracy you create is not high, and you reduce the cost for the government to do it. Esoteric dichotomy. Hey, Yaron, if health insurance is decoupled from the employment, would there be a phase where employers are required to fund individual HSAs or up wages? No, but that would happen. Employers would have no choice. Just competition would drive that very, very quickly, and employers would know that, so they would do it immediately. You could theoretically, force that. I don't like force. I don't like requiring things like that. But you could force the employer to provide that as an increase in wages or as an initial funding of HSA. But ideally, you just let the market develop in that direction. But yeah, one way to kind of spur it, is to say, okay, for the first year, that we've eliminated employer-based. The employer has to take whatever they paid the previous year and put it into a medical saving account for the, or health saving account that basically I'm using them interchangeably. Put them into one of these accounts for the employee. And that way we guarantee that everybody gets an account and has some money there to begin with, and then starts thinking about buying insurance through that and spending healthcare money through that. And that's a way to transition, I guess. You could do that. You could do that as part of the transition. But ultimately, you wouldn't want to force that. Barbara, when in the US, I use private clinics when possible and pay cash. My out-of-pocket cost is almost always less than copay with insurance. My copay is almost zero, so I don't know why you know, for you insurance is so expensive. Now I pay very high premiums for the insurance, but then my copays are very low. $20. I never pay more than $20. Can't remember when I paid more than $20. 22. Sorry, 22 is what I pay for my shoulder guy. Every time I go see him, my copay is $22. If I paid cash, my guess is he would charge me $100. Esoteric Dichotomy, I love these informative shows the most. Thank you. Thanks, I appreciate that. I'm glad you like it. Phil says the way. I'm not sure what that refers to. Alejandro says, I moved from a third world country to the US. The only area where my quality of life has declined is healthcare. That's interesting because I don't feel that way. I feel like I get phenomenal healthcare in the United States. So I just think you have to navigate the system and figure it out. And then once you figure it out, you can get amazing healthcare here. Not as good as it could be, but amazing. All right, guys. Thank you. Thanks to all the super chatters, particularly Wes. And Andrew did a lot as well. So thank you, Andrew. But thank you, Wes. Thanks to Wes, we made our target. So I appreciate that. I will be back. Tomorrow is a show in Hebrew, for those of you who understand Hebrew, at 11 a.m. East Coast time. So my show in Israel. And the next U.S. English show is going to be on Monday. I did not call for universal basic income. I called for universal basic income phased out over a generation. And if you don't include the phased out over a generation, and if you don't include the eliminate every other redistributive program that the government engages in, then you're misrepresenting my views, because that is what is important. So as an objectivist, I want to get rid of all the redistributive programs, lump them into UBI, and then phase that UBI out. That's how you get rid of the welfare state. I think that's also how you get rid of government involvement in healthcare and government involvement in education. Now, if you just want to treat them independently, is you can deal with them through medical saving accounts and education saving accounts, which are kind of UBI-like in the sense that the government gives you a cash payment. But UBI is an opportunity also to get rid of all the welfare on top of all of that. All right, everybody. I will see you all on Monday. Thank you. Have a great weekend. And yeah, let's hope we get a little bit of what I'm suggesting. And any one of these reforms would be amazing.